uveitis workup and its relevance in modern diagnostic armamentarium. So this case is aimed at the basic clinical setup in ophthalmology, where the clinician wants to practice uveitis, and at the same time a setup where there are so many new aims like medical institutions are opening up in India, and many of my colleagues are setting up departments there, so it is relevant from their point of view. I'll be starting with the basic practice of uveitis in a clinical setup. Is it feasible in an institution like New AIIMS or a new setup? Then Dr. Nitin Kumar, Dr. Anirudh, Dr. Swapnil will be discussing different aspects of uveitis workup and management of different entities. Dr. Brutendu, due to some unavoidable reason, could not be with us today. So Dr. Nitin will be discussing his topic, and in the end we will have experts' view on the need for elaborate laboratory tests and molecular diagnostic assays by Dr. Padma Malini. So what is the meaning of a basic clinical setup? So basic clinical setup entails a slit lamp, of course, with anterior segment photography, indirect ophthalmoscopy, fluorescein angiography with or without ICG, and OCT for sure with or without an OCT angiography. Basic microbiology is usually present in any clinical setup, even in a small private setup. Radiology, newer AIIMS have good diagnostic and interventional radiology, so that can be of help. Ultrasound B scan with ultrasound biomicroscopy is again easily available, and of course good clinical skills and referral from your colleagues. Slit lamp examination and indirect ophthalmoscopy is the beginning of the a uveitis case workup, where the detailed examination of cornea, the characterization of KPs, whether they are mutton fat, stellate, pigmented, give away a lot about the diagnosis. Cells and flare, the sun grading classification, it still forms the gold standard in a uveitis workup. Angle examination using gonioscopy and fundus periphery with indentation gives you a detailed view of the posterior segment pathologies. We often start with chest X-ray and Montu, and these are still relevant in today's times because India is endemic to tuberculosis, and tubercular uveitis is very, very common in our practice. Tubercular cause is also a great masquerader and presents as any form of uveitis. Chest X-ray is routinely done as a screening tool before starting high-dose corticosteroids or committing to immunosuppression, and often ordered before CECT or HRCT as a screening, since it's a lower radiation test. Montu again identifies latent tuberculosis, good correlation with uveitic process, universally performed with or without IGRA, and continues to be widely ordered and holds value in endemic regions. Uveitis and its complications are even more common in developing countries when compared to Western population, and occurs in up to 714 per 100,000 population and accounts for about 20% or 25% of all blindness. So developing countries often see a larger proportion of infectious causes of uveitis, and most of these etiologies can be diagnosed clinically using standard microbiology. So I am insisting on this is because it is important to at least practice uvea even in a basic setup, because the diagnosis and management requires a very basic setup, which I'll be elaborating in the cases that I show in the next slides. Commonly seen infectious uveitis in India are toxo, tuberculosis in different forms, and viral uveitis. The non-infectious, this list is quite long, but these are commonly seen entities, which I'm sure all of us have seen in our clinical practice and managed. I'll just show a few cases to show you that I am working in a very basic setup. Still, I am able to manage 90 to 95% of uveitis cases, and how it is important to not straight away refer to them in the because of lack of equipment. You should attempt to diagnose them clinically and manage them, and you are able to do that successfully in the majority of cases. So this is a straightforward case of young patient with acute course of disease with hypopyon, diagnosed as acute anterior uveitis, intermittent low backache, and HLA-B27 came out positive, was treated with topical steroids, and we see this is one of the commoner forms of anterior uveitis that we see in our practice. Does not require any elaborate investigations, does not require any elaborate imaging techniques, and the outcome is really good in these cases with good counseling and follow-up. This is another case where this is a middle-aged lady with granulomatous KPs, cataract, and this is actually a case of chronic uveitis with acute exacerbation. Patient was negative for tuberculous workup. Chest X-ray showed hilar lymphadenopathy. The patient was diagnosed as having sarcoidosis, and on treatment the patient is doing fine, planned for cataract surgery. So a simple ruling out of tubercular etiology, chest X-ray, and the characterization of KPs in this case can help us diagnose and manage this case nicely. This is another case where a middle-aged male with diminution of bilateral diminution of vision came with this picture, and on suspecting the systemic association because of these skin lesions, this patient was referred to dermatology and came out came as with the diagnosis of lepromatous leprosy. The treatment was given and patient is doing fine. This is another very common entity that we see in our daily practice, which is unilateral acute focal retinochoroiditis. The patient was young and had diminution of vision for a week, hyperreflectivity on OCT, and headlight and fog appearance. This is a very common picture. Treated with intravitreal Clindadexa, 5 doses. Patient is doing very well. The lesion was away from macula, so the vision is returned to near normal. This is the OCT showing resolution. This is another case where this patient is a young male, mild pain with diminution of vision. We worked up this case. Initially, we kept our differentials as choroidal granuloma versus posterior scleritis because patient had mild pain and there were some ILM folds present. On workup, MON2 turned out to be positive. So we, although the on FFA, this patient had stippled hyperfluorescence, so we did diagnose towards scleritis. However, the treatment remained the same with steroids and ATT. The patient is doing well. This is another case of a patient who had diminution of vision for last 2 weeks, young male, 20 years. History of being treated with corticosteroids in the past and PST Kenacort. However, this patient had no history of receiving anti-tubercular therapy. Patient was positive for tubercular workup. So we started the patient on systemic steroids, ATT, and because he had this CNVM, we gave the patient anti-VEGF, and this is how the membrane has contracted towards the disc and vision is returned to normal. So the challenges which can present to you are that other specialties in the institute may not be convinced with the systemic cause or association of your diagnosis, so you have to liaison with them and convince them. Documentation is usually a big challenge because of the paucity of online image archiving and viewing systems, so equipment procurement is the way to go. And the things to keep in mind in a basic setup is frequency and pattern of uveitis must be considered. Clinical exam with detailed history will clinch a majority of diagnosis. And most important is to identify infectious uveitis and avoid steroids straight away, cross-consult and meticulous record